We all know as patients just how frustrating today's healthcare system is, but we're not the only ones that feel that way. Doctors who are part of it also find frustrations that they have to deal with.
X-ray, CT scan, labs, and a subspecialist. How many months is that going to take you in the outpatient setting?
That's true.
The majority of healthcare happens outside of the four walls of a doctor's office. The current system, it isn't designed around patients. It's designed to perpetuate the system, and that needs to change.
And so today we're going to dig in and find out just how to navigate past those hurdles.
Have questions about your healthcare and not sure where to turn? We give you unfiltered insight into how healthcare really works. This is Give It To Me Straight, Doc, presented by Tampa General Hospital and our partners at USF Health Morsani College of Medicine.
Welcome to Give It To Me Straight, Doc. I'm your host, Anjalee Khemlani. Thank you for joining today. We've got a good one for you. I know you want to hear from the docs because we all want to hear from the docs. Dr. Jason Wilson, you are with the emergency medicine at the College of Medicine at USF Health and TGH. Thank you for joining us today.
Happy to be here.
Listen, ER is not a fun place to go because once you sign up for that train, you're waiting a long time. You're smiling because you know this is true. Okay, let's start off with tell us why ER takes forever to get through.
Well, let's think about a couple of things first and sort of just step back one degree here. The amount of things we can accomplish in an emergency department is incredible. It is the peak of coordinated care in the American healthcare system. You essentially have a place that runs 24/7, that has all the advanced machinery, equipment, innovation. That
everyone who's seen The Pit knows that now.
Which actually is a great show.
Yes,
and it's
it
the
is.
closest
Oh my
I've
gosh,
seen
love it.
to. It's all very compressed into one.
Do you feel like
one day.
it mirrors reality?
Over my career,
Yeah?
yes.
Okay.
And the phenotypes are all there of what we see, and the different personalities are there, and the challenges that we have are there. They're magnified because it's television,
Sure.
but they're there. But if we think about the emergency department as this 24/7 running place with access to all of this diagnostic equipment, all these emergency medicine physicians waiting to see you.
Yeah.
And then I think what's key that I think it's important for people to understand, subspecialists that are there to see you as well sometimes, or to get access to subspecialists. Because if you talk to people, what a lot of people will tell you, at least in the past decade or so, is oftentimes it's not necessarily primary care access that they're struggling with. That can be a little bit of a wait, and
Yeah.
sure, it can take a little time to get in that door. But even once they get in that door, the problem people struggle with is this next step when they have complex disease or they have a complex medical condition and they need a subspecialist to see them. Or they have that disease state diagnosed and now there is an exacerbation of that disease state and they need to get in to see somebody who really understands that disease state. So to bring all those resources to bear in one place and to get all that work done, I think about it this way. I think about the timeline being taken out and making an analogy in the outpatient setting. A lot of things we do in the ER, say 3 or 4 hours, because 3 or 4 hours, by the way, if you come into the ER and you're discharged in 3 to 4 hours, we consider that a success. So
I don't think any patient thinks that's a success.
But just to set the timeline.
We'd like 30 minutes, please.
I love 30 minutes, and remember the Domino's pizza thing, 30 minutes or it's free, right? But here's the thing.
Healthcare's free. I'm signing up for that.
Right. I didn't make any guarantees or coupons or promises. But if you go to the outpatient setting and you need to get a X-ray, CT scan, labs, and a subspecialist, how many months is that going to take you in the outpatient setting?
That's true.
Right? How many trips is that going to take you? How many prior authorizations of healthcare insurance is that going to take you? How many, that's the wrong appointment, I got to reset the appointment and try again? Versions of this. We've all been through that in our healthcare journeys.
Sure.
So you compress that all down to a very finite timeline. This stuff just takes time. And we're doing it for a lot of people at once. And of course, I think everybody knows this. The other thing that's happening in the ER as well is what is important right this very moment is changing constantly, right? There's
Based
anything
on who
can walk
comes
in the
in.
door,
Yeah,
right? I mean, I think we all recognize that
Yeah,
there's that
yeah.
aspect of emergency medicine.
We've seen enough medical shows to
That's
know.
right.
The
Yeah,
gunshot wound gets priority. So when we talk about, the sort of trajectory for people thinking about where to go, right? To your point, if they just put off getting care and then it escalates to an acute situation, which is why they end up in the ER, what can we do to navigate better? Because urgent cares also exist, but
Sure.
they're not built equally, right? I've just recently heard a story of someone who tried to do the right thing, go into the urgent care, and was sent to the ER anyway. And so if that's the situation and everyone ends up in ER anyway, what's the point?
Well, there's a lot of doors into the healthcare system, so one of the ways I think about it, through Tampa General, for example, is whatever door you walk into, we're going to get you the right place for the right treatment that you need, right? Whichever door, whether it's a family medicine practice door, a urgent care door, or right into the ER door, or the back door, a transfer to another hospital, right? You'll get to where you need to go.
Okay.
And this, I think the complicating part about that choice or that heterogeneity out there is it gives the healthcare consumer, the patient, a lot of options up front too. And so how do they pick which door to go to?
Well, because they're told to pick the right door for them. Like, I think the problem is that patients, to the point of the screen right now, the reason why patients think about ER is because they need something urgently. But the reasons why they should avoid it is what you're saying, basically, the cost, the burden on the clinical team, and it creates the delays that they end up then facing. But it almost feels like there is no way to properly wait for the right way or the right entry point other than being a really well-versed person on the health system. And it's almost like giving them extra homework at a point where they're the most vulnerable.
Yeah, and I think each person has to evaluate some of those points we saw on the last slide kind of on their own. And what I mean by that is cost. Let's talk about cost for just a moment. The ER is set up in this country to be able to see anybody, anytime, with any illness. So anybody walks in the door, we're going to take care of. And we don't ask you about your payment. We don't ask you about your cost. The doctor doesn't ask, right? There may be a conversation with registration about that, but we're going to treat you basically the same either way, regardless. So there's an access issue in this country around healthcare in general. Now, the cost may be higher for the payer, right? But the cost to you may be the same, negligible, no different, right? It may not matter as much. Maybe the cost to you of a person with no insurance is actually higher to walk in an urgent care door. So it just depends, right? Because you're going to have to pay something when you walk into an urgent care door. But if you have insurance, maybe it's actually better to go there because you are going to minimize the cost for you and the payer and your copay. So I think it's just important to say that it's probably each person has to think about that and evaluate that a little bit on their own. The burden on the clinical provider is not heavy in the ER. We're there to see people. I think that can sometimes be it doesn't mean, again, I think that the timelines we have to compress a little bit, that we're going to define success, right, by 3 to 4 hours to be able to go home. So if that ankle sprain
30 minutes.
Or that, cut on your finger or whatever, if you need to access the ER and you're willing to have 3 to 4 hours to do that, that should be the expectation walking in the door, versus if you're thinking this is a very acute minor thing, that's your thought process going in, then the urgent care may be a totally appropriate place. But there probably has to be some expectation this is a disease limited type of event, and I am not a incredibly complex patient.
Do you think that with the help of AI and the world we're living in with ChatGPT and asking ChatGPT, that might help alleviate the burden that patients feel is on them to make the right decision?
I'm not sure we're there yet.
Okay.
I'm not sure there's a problem trying sometimes either, because it can recognize some things that may be important. Maybe if you were to type in, I'm a transplant patient with a fever, should I go to the urgent care down the street? It'll probably, I don't know, I haven't tested this, but I'm going to guess it'll probably tell you no. You need to go to the transplant center with the ER there and see a person there, because you could have immunosuppression type of emergencies versus a common cold or a common fever. And, really that's just the way we should think about it as healthcare consumers too. What do I want out of this visit? What do I want out of this encounter? I'm a pretty healthy person, but this cough has been nagging me. I keep getting little fevers from it. I'm pretty healthy, but I remember my friend, my brother, my whoever, somebody had pneumonia one time. Maybe I should just go and just make sure it's not pneumonia, and maybe they can give me something that helps too. So maybe urgent care is totally appropriate for that patient. What I don't want to do is, the patient who doesn't have those resources to do that, there's no burden to us for them to come to the ER and have that, but they should have the expectations that they are also not allowed a trauma walking in the door either, right? And so there may be some time with that.
And I think the important thing too, if we could end on this, is also you do have to do the homework, even for urgent care. As we were talking about this before we started taping, which is, even an urgent care could not have some of the tools that are needed. So you might even have to call around. Does it have an x-ray machine? Does it have someone who can do labs, at that moment that you need to enter? So there is still a lot of burden on the patient.
Well, you bring up a point. A lot of the patients I see at an emergency department like Tampa General, which is a very complex level 1 quaternary care academic medical center.
Level 1 means it gets all the emergencies.
Right.
You need to learn these levels.
We take care of the sickest of the sick
Yes.
throughout the entire,
correct,
13 county area. Somebody can, pull up the number of counties we take care of. It's a lot of counties we take care of. And what I think about is those patients are the sickest of the sick. And most of those patients have actually seen somebody else. And a lot of those patients have been seen somewhere else and been sent in by a primary care doc or by an urgent care advanced practitioner because the resources were limited at the places they went. So I think that's exactly right. Is in this current day and age of healthcare, we do have to have a little bit of knowledge about what we want out of the encounter and also have done some homework. And I think the time to do that homework is now when you're not sick.
Right.
So kind of where you're going to need to go when.
What's near you.
What do they have? Am I going for an x-ray they don't even have? Because I think urgent care is totally appropriate for those types of things. If it's a finger laceration, is your finger moving? If your finger's not moving, you could have a tendon injury. You may need to have an emergency medicine doctor or a hand surgeon repair that. If it looks clearly like a laceration, everything is working fine, it's probably totally appropriate to go to urgent care for that patient, unless you have hemophilia and a bleeding disorder, because they're going to turn around and send you to the ER.
Oh my gosh, the layers.
Right.
Well, this is good. Hopefully, our audience learned a little something about how to navigate this system. Yeah. Thank you so much, Dr. Jason Wilson.
Anytime.
Appreciate it. Don't go anywhere. More about the provider side of this conversation next. Welcome back to Give It To Me Straight, Doc. I'm your host, Anjalee Khemlani. Today's show is all about the providers, the doctors, the physicians, those specialists, whoever you see, the clinical team in the hospitals, in the provider networks. We know that they actually do also struggle to navigate this health system. They see it, they understand our frustrations. And I had a chance to sit down with several who were willing to share candidly their insights. Here's what they all had to say.
The volume is very chaotic. You have huge surges of patients coming in, and they come in for all sorts of problems, from everything from, the earaches to the car accident to heart attack. So you have this wide variety of things. I think sometimes you do run into people who have issues and they have kind of time constraints. They don't have a way of getting into their primary care doctor. And so ER is the default to come in to get care. And so sometimes there are simple problems and you kind of feel bad for people because it's either probably something easily handled by a primary care doctor. This is a very expensive way to get care. Where they go to a primary care visit might cost them $10-20 on a visit, versus if they go into an ER setting, you're talking about thousands of dollars of billing.
I have come to appreciate that the majority of healthcare happens outside of the four walls of a doctor's office. And, it's happening between caring for your family. Healthcare is happening when you're managing work stress. And it's happening outside of those encounters with me. And the current system, it isn't designed around patients. It's designed to perpetuate the system, and that needs to change. Now, the good news is there are people working on solutions. So we've seen a lot of organizations like Amazon One Medical intentionally design around the patient experience, around access, and around engagement. So if I had to distill the problem as a PCP, the healthcare system is complex, but patients shouldn't have to shoulder the burden of navigating the system on their own or becoming experts in insurance bureaucracy just to get care.
One of the biggest problems is the payment system. I'm an oncologist, so one example is that we have the ability to assess the DNA and the RNA pattern of a cancer. It's called genomics, next generation sequencing, and the insurance company will pay for the test, and then the test tells us for this cancer, for this patient with this genomic mutation, you should give this drug, and then they won't pay for the drug, which makes no sense. Then why pay for the test? And you eventually get the drug approved, but you have to go through a process that costs inconvenience for the doctor's office, expense, stress to the patient, and a delay in starting a necessary treatment.
When you think about it, if you take the perspective of each specific entity within our healthcare system, what they are trying to do makes sense. So let's think about a hospital or a multi-specialty clinic that has decreasing reimbursement coming from Medicare, increasing cost of labor over time, and small margins with seeing patients usually. If you were that healthcare entity, what you would say is we need to be more efficient. We need to be able to see more patients, because if our margins are smaller, we just need more volume. And so we need to bring people in efficiently, get them out, get them treated. And so that's what you do. If you were a health insurance company and you see that your costs are rising in these specific areas, like these drugs that have good data for them, but they are costing us a lot of money to in our business model, you would find a way to try to restrict access to those medicines. So when you look at what each player, where they're coming from and their angle, what they are doing and what they're trying to do makes business sense. But then at the end of the day, when you boil it down to a patient and a doctor in a room, it's like none of it makes sense anymore.
So you heard it straight from the horse's mouths. I mean, they struggle with it too. We struggle with it too. We're all in this together, and we're going to hear more about that on the other side of this break. Welcome back to Give It To Me Straight, Doc. I'm your host, Anjalee Khemlani, and I'm really excited about our next guest because you actually just saw him. He's the one who laid out like a perfect professor exactly how the healthcare system works. And it's my pleasure to introduce Dr. Tyson Bell, University of Virginia, Department of Medicine interim chair, hopefully soon to be chair. We're rooting for you. Dr. Tyson Bell, thank you so much for joining us. And thank you for understanding the health system so well and being able to distill it down for all of us who do not know it as well. I want to start off at a point that most people, I don't think, understand about this health system being so complex that even you as a doctor know how complex it is. And you shared with me a lovely little anecdote about how you needed care and you basically just went to the doctor that you know could handle it. But we can't do that, right? Like the decision tree of how we as patients get to the doctor is this. It's what's on your screen. It's this insane system of we go without knowing much about how we're going to get there and what we're going to get as a diagnosis or as a prescription and whether or not it's going to get approved. But you can kind of bypass all that, right? Totally.
Well, I have connections with the medical system, so I find ways to get around it if I have to. And I try to go through the rules just like you're supposed to, but it can be hard sometimes because you just know sometimes there's just obstacles in your way just because they're in the way and not because they really make sense. And so we try as much as we can, but every now and then I might just call the phone and just ask, can we just get this done and make this happen? At the end of the day, people go into medicine because they want to help people, and trying to make a connection with someone is sometimes the way to do it. And oftentimes, if you are a physician or a nurse and you get contacted by someone in your community or you get stopped, then you're going to want to help that person too.
Yeah, and you're not alone, right? We've heard this from multiple doctors who have been on the show, and exactly to your point, one of our very first guests said exactly that when you get into medicine, it's because you want to help people. I fought back and said there's some people who get into it for the money, which is the other part of it. but that is where the tension comes from, right? Because at the end of the day, it is a business, and you did say that. At the end of the day, it is a business, and each side of this very siloed but interconnected, ironically, business is trying to make money and stay afloat, right? So
Right.
On the side of the doctors, I kind of want to go on a tangent and ask you if just like a house call doctor was the best way to go about it, but that was like not a sustainable business model. So, so now we're in a world where many practices are owned by entities, be it a third party or a hospital system. And then you have on the other side the insurance companies. And that's where this tension comes from, right? There's the cost side and then the care side. And that tension is really hard to assess, and patients just get stuck in the middle of that. How do we as patients bypass it? Because we don't have the same phone number as you do.
Yeah, I think it starts with trying to have a conversation with the people that you have a good relationship with. And oftentimes, your doctor, I'm sorry to say, we don't understand this business as well as we probably should because medical school doesn't really cover this. And so when it comes to trying to find a new medication that you want to start, let's take an example with the GLP-1s.
Ah, great example.
Like Wegovy and Manjaro. They're very good. They're fantastic, but they're so expensive. And I just had a patient or a colleague actually go through this. Went to the doctor, wanted to start the medication. The doctor wanted to start the medication too, but it was denied. And from the health insurance standpoint, well, actually, let's go back to the pharmaceutical company. Make this medicine. It's going to be on patent for only a limited amount of time. They want to make a profit. They keep that price high. Health insurance company being contracted by whoever the employer is, because we have an employer-based system for better or worse, sees that their cost is going up. And I actually spoke with an employer who said that over half of their year-over-year increase in costs was due to these specific medications. And so what do? They have to restrict it. And when you restrict it, you go through a prior authorization process. Your doctor sends a prescription, it gets denied. Most people know in this business that if it gets denied, the doctor's not going to take that extra step because they have 25 other patients to see. And so now you go to, you either don't take the medicine or maybe you find a compound pharmacy or you find it in Canada if you're in upstate New York. And now you're taking a medicine that you're not exactly doing it the right way. Maybe you have a side effect. You end up in the emergency room. And because these medicines can cause side effects,
Yeah.
and now you're in the emergency room, you get a CAT scan, and now your insurance cost goes up because the overall cost of the plan is starting to go up and your premiums rise. And so, how do you bypass all that? I think one way is to always think about what the alternative is to what the recommendation is. And so, if your doctor wants to start a particular medication, ask, is there a cheaper alternative? Where could I get that from? Is there a different place I can go to? When you go to the pharmacy, ask this question as well. Sometimes, and I learned this recently, sometimes your cost of your medication might be higher because of the plan that you're on.
Yep.
But if you ask for it over the counter, or not over the counter,
Or
but if
cash. Yeah.
you ask for it to bypass insurance, it might actually be a cheaper prescription to do it that way. And that's not always allowed, but you can always ask a question. And so the curiosity to find out, well, I hear what you're saying, but is there a different way to do this that makes it more affordable for me or makes it work better for me? And oftentimes the physicians are frustrated too. And if they find a way that they can make this work better, then that's something they can pass on to their patients.
It's funny. It's like you've been watching our show. We actually had a pharmacist talk about the whole over-the-border prescription filling. But to bring it back to what you were just talking about, I think it's also interesting because, you know, it doesn't dawn on the patients that we should be asking doctors more questions. I think there's this whole, you know, this idea of like the paternalistic patient-doctor relationship that some have tried to do away with. I think you see a newer generation looking for more answers, going outside, right, of the usual traditional space, asking ChatGPT or Googling their symptoms or going to direct-to-consumer avenues to try and get care because they're so frustrated with the traditional system. And so I just wonder about how we should be thinking about the plethora of access points we now have, and how should we as patients navigate those points and know when it is maybe okay to rely on a DTC platform or telehealth platform, and when it's really important to make sure we see a provider and get in with the doctor.
Yeah. Well, one thing I would say first off is that you talked about this healthcare interaction when a physician interacts with a patient or a nurse practitioner interacts with a patient. I think one thing to realize is that there is a power dynamic that's sometimes at play when you go to see the doctor because doctors spent so much time developing a medical expertise. They're an expert in their area. And I read a statistic that in medical school, you learn something like 10,000 new words, and that's the equivalent of being born and becoming a toddler. And so you literally learn a new language becoming a physician or becoming a nurse practitioner. And sometimes we use big words and that can be intimidating for patients. And so if you don't have a question or if you have a question, sometimes you don't feel comfortable quite asking it because You don't want to waste a doctor's time, or you're just embarrassed that you have that question. One thing I try to do, I tell patients when I walk out the door, you're going to think about something. You're going to say something. You're going to call your friend, or you're going to talk to the person next to you, and you're going to tell me what you really think about what this plan is. Tell me what you're thinking now. Ask me your questions now, and believe me, anything that I've been asked before. Or sometimes I try to anticipate what those questions might be and say, if I were you, I would be wondering, is there a better way to do this? What's the alternative? And offer that up from the beginning. But I think if we take the relationship and make it more of a service, you're coming in to get a service from the doctor, from the nurse, which means that you have that service, which involves education in a medicine or a procedure. You need to understand what exactly they want to do, why they want to do it, what the alternative is, and what's the best way to access that care. And if you have that structure for a visit or interaction, then oftentimes you can start to ask those questions and get the answers that you need.
I think well said. That's a lot for patients to think about. And thank you for explaining it so clearly and not using your GMAT words. Dr. Tyson Bell, University of Virginia Department of Medicine Interim Chair, thank you so much for joining us today.
Thank you for having me.
I've been your host, Anjalee Khemlani. You've been watching Give It To Me Straight, Doc.
And we're here to hear from you. If you have a medical question you've been unsure about, ask us. We feature real questions from real people on the pod.
Don't forget to join us next time, and also don't forget to scan that QR code on your screen.